Let's start with, I know that you're a professor at Harvard University, but you're also an endocrinologist, right?
Mm-hmm.
Did you start in endocrinology and work as an endocrinologist and then move into research, or what did that look like?
Yes and no, right? So the way the system works here in the United States is that as you progress through your training, from student to resident to fellow to, you can either do only clinical, if you want to do only clinical, or for some of us who aspire to be researchers and educators, then you can follow a different path. So from the beginning, right, during my student years or residency, I started doing clinical and research at the same time. So having 2 or 3 jobs instead of one. So I trained after medical school, I trained in internal medicine, and then focusing on endocrinology, diabetes, metabolism as a specialty, and clinical nutrition as a subspecialty. And I did research in the lab, basic research, and we try through observational studies, epidemiology, to raise hypotheses about what happens in humans. And then we translate what we are finding in mice or in epidemiology into clinical trials and new knowledge that we apply in humans. So I have informal and formal training with master's and doctoral degrees in epidemiology and basic research. And I do all 3 at this point. So I see patients. I have a big lab with a lot of students and fellows who do research. And we also do clinical trials and participate in committees that we write guidelines on how to apply what we find in our research into guidelines and recommendations for people.
Has your work crossed over much with Walter Willett at Harvard? Do you know Walter Willett?
Yes, I know him very well. He was one of my professors when I was a student, and we are good friends now. So when I was a student, a couple of decades ago or more, time flies, when I was deciding what field to follow. At that point, pun intended, right? The elephant in the room was the rising prevalence of obesity, right? As a society, we would become more and more obese, right? So was this nutrition? Was this lack of exercise? We needed to give an answer, right? So I got a master's degree at the School of Public Health, and he was teaching nutrition, and he was my professor. I was also doing epidemiology with the late professor and head of epidemiology, my mentor, Dr. Trichopoulos, and they were very, very close, best friends. So we became friends over the years.
How has the landscape changed since then to now? As an endocrinologist, are you seeing the same conditions as you saw early in your career as you do today?
Again, yes and no, right? As we progress, we're learning more, right? So when we started, for many, obesity was a cosmetic problem. It was just how we appear, right?
So there wasn't a link between the excess body weight and metabolic disease.
Exactly, right? And if we draw an analogy, if I may, right? And we go back to 1940s. People were looking at blood pressure as a normal variant. Was not linked to disease at that point. Blood pressure was high or low, but and there's turning points in life, right? Personal lives or professional lives or the lives of societies, right? And at that point, a beloved American president, President Roosevelt, started having small strokes. And he died at the end. And this was because of high blood pressure. So people started doing studies and linked blood pressure with strokes, late 90s. Follow me for a minute, right? I hope I'm not...
I got you.
And then what we had in early 50s, we said we need to treat, our colleagues at that time, we need to treat blood pressure, right? What was available to us? crude sympathectomies, surgeries, to cut the sympathetic system. So from that, the doctors learned what is changing after we cut the sympathetic nervous system. Can we create medications to block it? And then can we improve the medications that in the beginning had a lot of side effects and then less efficacy? Can we refine it? And then can we find other pathways? And now we have several medications we can treat blood pressure. Yeah. If you go back in terms of obesity 30 years ago, people would say it's a cosmetic problem, lack of will. Nothing to do with hormones, metabolism. Then we realize that as we get more obese, we have a metabolic syndrome. Excess fat leads to high blood pressure, diabetes, cardiovascular disease, right? More recently, we learned that it is linked to fatty liver disease. More fat in the liver is responsible for non-alcoholic fatty liver disease. And now we realize that about 30% of cancers are related to obesity. So I teach my students, if an angel would come to our world and make obesity disappear, about 65% of endometrial cancers would disappear. About 30% of epithelial cancers, like breast cancer, prostate cancer, you name it, right, would disappear. And what most people don't realize today is that a lot of neurocognitive decline, Alzheimer's, Parkinson's, is related to obesity and metabolic syndrome. So that's why the rising prevalence of obesity leads to the rising prevalence of all these diseases. So scientists focused on this, and there was a turning point, 1994-95, so close to 30 years ago. And this was the discovery of leptin, a hormone, the very first prototype adipocyte-secreted hormone. And when we gave it to mice, they lost weight.
Mm-hmm. Less appetite.
Less appetite. So that was the first proof that gaining weight or losing weight, anorexia nervosa, right? Mirror images, is not only lack of will. There is biological mechanisms that underlie this lack of will or less will or stronger will that some people have.
Right, so different physiology could mean different drive to eat.
Exactly. And then this created an explosion in the field, right? So leptin is not the only hormone that is secreted from fat to give to the brain the message how much energy we have stored in fat. In lean people, you are lean, right? You receive the message. You change your appetite and the way you exercise.
So that would be, I'm leptin sensitive?
Sensitive. And there is some people who are leptin tolerant. So leptin may go up, but they do not respond, right? And then we realize that leptin is only one of the adipokines. There are dozens. The system is very complicated. We need artificial intelligence. We were talking about artificial intelligence. But then we realized that the brain receives messages from other organs, right? And it makes sense if you think about it. You don't need to be a rocket scientist, right? So muscle, we exercise. Of course, the brain needs to receive a message from myokines, hormones that are secreted from muscle, goes to the brain, changes the way the brain approaches food and exercise, and gives feedback to muscle. What is the most important organ for our food, right? The GI tract, the stomach, and the gastroenterology tract, right? There is incretins, hormones, and we realize one after the other who they are, and we study them in the lab, that the stomach and the GI tract secretes hormones that go back to the brain and tell us after we eat, stop eating.
It's like the brakes.
It's the break. So this is a short-term break. And leptin is more longer-term signal, right? So how much energy we have stored in our body, right?
So that short-term break, are you speaking of hormones like GLP-1?
Like GLP-1 was the prototype, GLP-2, and you name it, right? So now we realize that there is a big molecule called pre-pro-glucagon, and it's cleaved into several other products like 8 of them. And it's differentially cleaved in the brain, the GI tract, and our pancreas, right? And all these hormones, number one, in physiology, provide feedback to the brain. In pharmacology, we are leveraging this now, right? To create medications that are stronger and last longer. Do you understand?
Yeah, so
that we can...
You know your point about willpower?
Yeah.
Do you think, it sounds like it's not really an even playing field. Like some people are dealing with heightened hunger relative to the next person.
Right.
Is it that you put on weight and then as a result of that you become leptin tolerant, or is it that, be it genetics or other reasons, certain people are just more leptin tolerant or have less GLP-1 sensitivity from birth?
Yes. No, this is a very good question. And we tend to believe these days that, and this is our culture out there, right? That there should be no differences, everybody is equal, and we are equal, and right? But in terms of our genetics, we are so similar, but also so different, right? Some of us have a predisposition, right? To be more obese or to be less obese, right? Or predisposition to develop diabetes. Even if you have obesity, I mean, let's go deeper, if I may, right? Not each and every, and we have realized that not each and every obesity is also the same. So some of us have more or less storage space in their adipose tissue. Mm-hmm. All of us have the subcutaneous adipose tissue.
I've heard people describe that as a personal fat threshold.
There is a threshold, right? So some of us have a small storage space. Like think about your apartment, your house, right? And you have your storage room, right? Some people have little storage space. Others have plenty of it, right? So for those of us who are fortunate to have a lot of storage space, potentially, in our subcutaneous adipose tissue, you can store their fat, your body weight can increase, and to the extent that fat remains where it is supposed to be, in the subcutaneous adipose tissue, you have no medical problems.
So if it stays in the storage room, not a problem.
Not a problem.
But if it's overflowing into the living room and the kitchen,
that's when you start creating problems.
Right.
So about 22% of people, especially women, maybe slightly more obese, if fat is not spilling over in other organs, we call them metabolically healthy obese. Could be chubby or obese. There is no problem, no need to treat them, right? But if the fat goes where it should not be, liver can cause fatty liver disease, can cause cirrhosis and liver failure, death over a period of decades, right? Not over a period of months. If it goes to muscle, it causes insulin resistance for people who are predisposed to develop insulin resistance. And the longer and the higher the degree of insulin resistance, the higher the risk to develop diabetes. If it goes to our vasculature, it's the same process. Atherosclerosis. It goes to our brain, right, and causes inflammation, neurocognitive decline, Alzheimer's.
So you got to keep fat out of the muscle, fat out of the arteries, fat out of the liver, fat out of the brain.
And right. And the very first, right, and most indicative marker is the belly fat, intra-abdominal fat, right? So if you see intra-abdominal fat, you know that most probably you have fat in muscle, you have fat in the liver, you have ectopic fat.
Other than just observing someone, is that something that you would become aware of through doing a blood test and looking at biomarkers, or is it a scan?
Yes, that's beautiful. That's a beautiful question. So this is work in progress, right? So we started several years ago with a crude indicator, BMI, body mass index. And this was started by insurance companies, Simon, because they had an interest and they still have an interest, right? So BMI is a simple crude index correcting weight for height. But we realized that this is not, as we realize what is happening, that this is not reflecting ectopic fat or, right? So then we started looking into waist circumference.
Which is a little bit more specific to like body fat distribution.
Exactly, a little bit more specific, right? But again, different races have different numbers, and they tend to have, say, Southeast Asians, they tend to have lower BMIs, but for a lower BMI, they don't have a lot of subcutaneous tissue. They accumulate fat in the stomach, but still is not the best, right? We need to refine it. So now, inexpensive markers, right? We correct waist circumference for height. We have to correct it, right? Because the waist circumference depends also on height, right? But if one wanted to be even more specific, we now know which are the hormones that are secreted from overall fat, and this is leptin. You gave it the hormone leptin from the Greek word leptos, meaning thin. And we are talking about obesity, but I can explain to you about what happens in anorexia nervosa or thin people, right? Because these are mirror images. And there is another hormone that we have done a lot of work on, is called adiponectin. And adiponectin reflects the intra-abdominal fat. And this is a hormone and an inflammatory marker, anti-inflammatory marker. And the more the intra-abdominal fat, the lower the levels of this hormone. The higher the risk for diabetes and fatty liver disease and cardiovascular disease. So you can measure it.
So the more intra-abdominal fat,
the lower the levels of this beneficial protective hormone.
Adiponectin.
Yes.
And you can request that on a standard blood test?
Most laboratories should have it. The big laboratories have both of them. It's not yet standard biomedical practice, but we are getting there. It's research that is becoming practice. But if you go to LabCorp or I don't want to, advertise any, the big national laboratories, they can measure it. Now, you mentioned about scans, right? MRIs or CAT scans. Yes, we can measure it. With CAT scans or MRIs, we can measure not only how much fat you have, but also whether the fat is in muscle or in the liver. Mm-hmm. And they're pretty accurate. The problem is that they are expensive. Mm. So you cannot do it many times. You cannot follow people with that. You can break the bank, right?
What do you think about a DEXA scan or liver ultrasound?
Yes. So the liver ultrasound, and there is several companies that are making ultrasounds for the liver, is very specific, but not sensitive enough. So if you have more than, let me start by saying that a normal person should have no more than 5% fat in their liver. So the ultrasound is very specific if the amount of fat in the liver is more than 30%. Between 5 and 30% is a gray zone that is not pretty good in picking it up. So if you have a lot of fat, the ultrasound will find it. But if you have between 5 and 30%, is not as good as an MRI or measuring it.
So that makes it not a great option for
not a great option
for a lot of people who might be on the fence.
No. We are not using ultrasounds these days for fatty liver disease.
And DEXA?
DEXA scan is pretty good in terms of overall fat. We don't have it. It's not available like everywhere. It's not as expensive as an MRI, but more expensive than running a hormone. Cannot tell us a lot about which organ has fat or not, but it can tell us the overall fat mass, yes.
So if someone's kind of listening and they're just thinking, I'd like to generally know where my metabolic health is at. Waist circumference to height ratio.
Yes, for sure.
And any particular blood biomarkers that you would also
Yes,
want them to look at?
if a laboratory has adiponectin, I would run adiponectin. Another very simple measurement is triglycerides over HDL ratio. So if you start having ectopic fat and insulin resistance, your triglycerides keep going up, and the good cholesterol, HDL, starts going down. So this is a red flag.
Okay. So triglyceride to HDL ratio, waist circumference to height ratio.
This is how I would be starting. And then if you see that these are abnormal, if you see your primary care doctor and you see these are abnormal, I would run a panel, right? The full cholesterol profile, glucose, right? One by one, right? The diseases that we know of, right? There is non-invasive tests like FIB4 for fatty liver disease, uric acid for arthritis, right? And you name it, right? So your doctor will prescribe these.
Ectopic fat, just to define that for the listener. So that's fat inside an organ?
Yeah, so ectopic fat, I don't like this as someone who is of Greek descent, but that's how we call it. Ectopic is, ec means outside of where it should be. I think this topic should be a better word, if I can use. But this reflects fat in areas where it should not be. It could be inside an organ, like fatty liver disease, right? Muscle, or just intra-abdominally, in the abdomen. It shouldn't be there.
Which is visceral fat.
Visceral fat.
Gotcha. Okay. So really what we're talking about here when thinking about metabolic conditions is a problem that stems back to storing fat in the wrong place.
Exactly. And I'll tell you why. I mean, maybe I can spend 2 or 3 minutes describing more in depth. The process is generally the same. There is small differences, right? I will use liver as an example, but one can think also about the vasculature. It's the same. So if more fat goes to the liver than it should be, right? More than 5%, 5.5%, right? Our own body is programmed, is created in a way to defend physiology. So we realize without us thinking about it, our body thinks that, well, it shouldn't be there. I need to remove it. So what do we have, right?
Some sort of inflammatory response.
Yes. So we have macrophages. So macrophages go there to eat it up, to phagocytose. Trying to help.
So this is a repair effort.
It's a repair effort. And in this effort, it creates more cytokines and the inflammation goes up, right? There is a hot area, inflammation there, right? More macrophages, more cells are trying to remove it. If we help with diet and exercise, they will remove it and the inflammation will go down. But if this continues for months and years, then we go from fatty liver disease to steatohepatitis, which is inflammation, permanent inflammation. 20-25% of people who have more fat in their liver than they should will have steatohepatitis, permanent inflammation after 5 to 7 years. And another 25 to 30%, what happens with inflammation? It's like a lot of fire, then you have burnt woods, right? You have scarring. And scarring, we call it fibrosis or cirrhosis. That's what it is, in essence. So the liver starts shrinking, and at the end of the day, you may end up with liver failure or needing a transplant. It's exactly the same, in a way, that happens. I'm oversimplifying, but I'm not inaccurate scientifically, right? Happens in the vasculature. So we have fatty streaks and areas with excess fat, inflammation, a fibrous cap, and then, right, we may have occlusion of the vasculature and either strokes or heart attacks. So the process is the same. So in a way, at this point, we need to limit fat. This is the root of the problem.
So let's go further into the root of the problem.
Yes.
Where's that fat coming from that ends up in the liver?
Yes. So this is, we were designed, right? And we lived as humans, right? Our world has a history of what? 13 billion years, right? Our species has a history of hundreds of thousands of years. Most of our history, we lived in societies of scarcity, not affluence.
A lot of famine.
Famine. So we are programmed, right, to metabolize the calories we take in and store them. There was no refrigerators, no freezers at that point, right? So store them. And we are very efficient. And our societies of affluence are not making things easier, right? We have high calorie dense foods, right? We have more fat and lipids in our diet than we used to have throughout our history, right? And we exercise less. We have less demands. We don't burn as many calories as someone who is a farmer, right? Or a builder, right? Because machines are doing the work for us. So the energy balance is against us, right? So if we don't watch what we eat, right? And this takes time, right? Our brain gets used to it, right? And over time, we are leptin tolerant and we develop more fat. And after we exhaust our storage space, it becomes ectopic fat and dangerous fat, right?
What explains the difference between why one person can store more fat subcutaneously than the next person?
Yeah.
Presumably there's some type of genetic difference.
Genetically and epigenetically, we have different adipose tissues storage space, and this is differences between individuals, but also differences between ethnic backgrounds. I told you earlier that a BMI reflects overall obesity in Europeans or North Americans, right? But if you go to Southeast Asia, BMI has no relationship, right? People don't put a lot of fat in their subcutaneous tissue; they just put it direct in the abdomen.
Right. So for a given BMI, they'll store more weight.
Exactly. So for a given, say, percent fat, or for a given amount of fat, right, kilograms or whatever, they put it in their abdomen, intra-abdominally, not
which is why they have a different BMI classification.
That's why, this is why we are leading now to having different classifications, because lower BMI is more dangerous for certain people.
So if we think through that evolutionary lens for a moment here, you spoke to the fact there that throughout evolution, humans mostly have existed in an environment of food scarcity. So it makes sense to be really well adapted to store body fat. That helps you survive. Critically important to reach an age to procreate. That's what evolution cares about, right? Mostly. But is there an evolutionary advantage for storing fat viscerally, perhaps? Do you think?
I don't think so. There is an extra fat, right? The fat will have to be stored somewhere. But let me go, before we go into this, you gave me an incentive to talk about some of our work, this is close to our heart, about reproduction and fat, right? So I think people out there realize that, say, college-age women or young women who exercise a lot, right? They have a lean physique. They cannot conceive. They have reproductive issues, right? And if you push it all the way to anorexia nervosa,
they get osteoporosis.
Exactly. So this may manifest as osteoporosis or even stress fractures, like small bones that they fracture as they exercise, right? And people say, well, I exercise, I'm an athlete. How come I have low bone density? And how come, and then you go deeper, right? Their reproductive axis is shut off and they have hormonal abnormalities, thyroid is abnormal, IGF is abnormal, you name it, right? So when I was a medical student, we could not put all these together, right? And I created a certain line of research as a young investigator when we discovered leptin. So leptin is the signal that goes from the fat, very simple, right, to the brain to notify how much energy we have stored in fat, right? So the idea was, if leptin levels are low, right, so we don't have a lot of energy in our body, what would our brain do? So our brain does not understand, the brain of someone who exercises a lot or has anorexia nervosa does not realize that we have a freezer or a fridge, right, to store calories. Our brain realizes we cannot survive. We don't have enough fat to survive, to live. So what goes first, right? It shuts
reproduction off in order to survive.
So it makes no sense for a woman, right, to become pregnant, because she cannot bring a pregnancy to term. She needs to survive herself, right? So the very first thing to go is the reproductive axis, right? And then it also makes sense for the thyroid hormones that regulate metabolism to go down. We have a slower metabolism because we conserve energy. And then IGF-1, which is the insulin growth factor that grows our muscle, also goes down, right? Because this is not a priority to build muscle. Here we have survive. And we have another system that we studied a lot. It's the activin-follistatin system, which is a beautiful system. In the beginning, it was called activin because it activates the reproductive axis. But we realize now that in starvation states, activin goes down. So it's a second system to block the reproductive axis and make us survive, right? But at the same time, it also has effects on muscle mass, bone mass, and insulin resistance goes to the liver and make each and every drop of energy we have stored in the liver and fat available to us to survive. And it's clearly, and we have proven this in animals and humans, the effect of leptin. So as leptin goes down, all these mechanisms are activated. And if we give leptin back to people, we start restoring one by one all these mechanisms. So which is beautiful physiology, right? But also beautiful therapeutics, right? If you think about it, because we have not been there yet. But if you think about it, these two systems, if we give it back, the activin, follistatin, and the leptin, we can prevent fractures. We can treat fractures. And we have done proof of concept studies. We gave leptin back, and we have shown this, right?
So is that an indicated?
It's not indicated at this point. So in medicine, the way that knowledge progresses is you start from animal models and in vitro. Then you go to epidemiology. So you either confirm or refute your hypothesis, right? And then you go to phase 1, phase 2 clinical trials. Phase 1 is safety. First, do no harm. Go back to Hippocrates like 2,500 years ago. First, do no harm. So phase 1, safe. Phase 2 is proof of concept. So clinical trials, we randomized women who were strenuously exercising, women athletes, rowers and dancers, and you give to half of them leptin and half of them placebo, and you follow them for a year or 2 years, right? And you see what happens to their hormones and bone mass. And we proved, right? It's proof of concept. We proved that bone density goes up by 6-7%, and you normalize all the hormones and everything. And then to get to the market, you need a company to come in and say, okay, I will do the phase 3 and phase 4 studies, right? Phase 3, you need at least 2 phase 3 studies to prove to the FDA that you can market it. And you need 2 phase 3 studies from 2 independent groups. And we can talk why. But
I want to come back to fatty liver, but just quickly to tie the knot in that, do you get a similar increase in leptin and normalization of that other system with that person if they increase the amount of food they're eating and reduce their exercise?
Yes, exactly. If you increase the food intake, right, energy intake, and decrease energy expenditure, you will get to the same point, right? But it is as difficult as telling to an obese person, exercise more and reduce your food intake. This is mirror image. So most obese people can decrease their food intake and exercise for a while, but predictably, right, after a few months, the system fails and they have to defend their original body weight. So they will go back.
Right. You see in most diet interventions, short term you get some weight loss, but from years 2 to 5, like most of the weight's regained.
Yes. Yes.
So you're saying the similar thing happens in reverse to these people.
Mirror image, right?
These are
so
people
if you tell a woman with anorexia nervosa or strenuously exercising woman athlete, right, a rower, or we have like 5% of college-age women. Boston is a college, it's a college town, right?
One of the first signs is the loss of period, right? Amenorrhea or irregularity.
Exactly. This is the first, and there is a hierarchy of responses. I mean, you're right on target. But most athletes don't think about it. It's convenient. And if you're a student, you don't have to worry about it for exams and everything. They don't think about downstream effects. Yes, you are right. Let's talk about it for a minute. So there is a hierarchy of responses. The very first thing that goes is reproduction. I mean, this does not affect our own body, right? It's okay, prevents, procreation, right? And then you have, as leptin goes lower, the thyroid, the IGF-1, and if you go very, very low, you're really cachectic, your immune system is also affected, right? We talked about immunology, inflammation in obesity. It's exactly the same, right? Th1, Th2 imbalance. So think about emaciated people in Africa who have all these infections and they die from infections, or people who die from tuberculosis, right? If they're extremely thin. So I diverge for a minute, but it's a mirror image. So if you tell a woman who exercises a lot, right, try to eat more, right, and exercise less, they will look at you and, are you nuts? What are you talking about? Sorry for the right? But that's what they're telling you, right? And even if they don't tell you, they're not going to follow you, right? The same is true for obesity, as you said. A few years ago, we did a large study and we followed people for several years, 10 years. 5,000 people, 10,000 people with diabetes, randomized in two groups. One was 5,000 people, multi-center, controlled trial. Go home, lose weight, follow the advice of your primary care doctor. And the other one, follow toolbox approach. Everything that we could. See a dietitian every 2 weeks. Exercise physiologist. Take medications, like not the medications we have today, but the medications we had a few years ago. And predictably, people would lose with the intensive intervention about 9-10% year one, and then they would start regaining it.
Why is the body fighting back despite having excessive body fat?
It has excessive body fat and is used to it. Let's put it this way, right?
It's like a new set point.
It's a new set point. It has to defend the original set point, which is crazy, right?
But I can't remember it's the set point from before you were overweight.
Exactly. So it probably needs more time than a year or two, right, to go back, right? Or more progressive weight loss. Because that's probably how we are built, right? We are built to adjust.
So you gain weight, let's say you gain weight and you become 100 kilograms or 220 pounds. And you are at that weight for some time. Now your body essentially says, this is our
my new normal.
And from that point, 100 kilograms, you go on a diet, you lose, let's say 10 kilograms, you're at 90. Your body is confused and says, we need to get you back to 100.
Yes. And I think that similar to each and every system, the faster you lose the weight, the more pronounced is the desire of your body to go back to baseline, right? you have to adapt to a new environment. And our body needs time.
To resensitize those systems.
Right. So, for example, one of the questions, we did not talk about the new successful medications, right, for weight loss. But one of the questions that we have for people with respect to the new medications
like
that are
Ozempic.
expensive. Ozempic or, I don't mean to advertise one, but Ozempic-like medications. There are several medications, right? And now we are discovering even stronger medications that will be available like in a couple of years. So I call them first generation, second generation, third generation. The first generation was what we had at our disposal before 2010, 2012. And we would be happy with 5% weight loss for most people. Second generation is what we had in the past decade, GLP-1 agonists, 10, 15% weight loss. What is coming now to the market, 2022 to 2030, 25% weight loss. And we're learning Sustained.
Over like 12 months, 24 months?
Well, at this point, we know a couple of years, most probably longer.
And that's because it's acting on these regions of the brain that drive appetite or hunger.
Yeah, we don't know everything that we need to know, but we know the basics, right? So let's go back to the example I gave you earlier about bariatric surgery. I told you about surgery for hypertension, bariatric surgery, right? So people who undergo surgery to lose weight, they may lose 35, 40%, 45% of their body weight, right? But we also know that there is certain changes of hormones in their bloodstream. So GLP-1, for example, goes up. GLP-2 goes up. More recently, we studied other hormones, oxyntomodulin, right? You don't want to confuse people with names. That's what we do, or pharmaceutical industry does, when they create the new medications. So they started with GLP-1, one medication. Now the next generation, third generation, is GLP-1 plus GIP, duals. And we're going to have triples or quadruples, cocktails. So all the hormones that are changing after bariatric surgery, you put them into one medication. And instead of having surgery, you give this cocktail.
And so the idea, I just want to say if I'm hearing this right. So I gave that example of say someone that got to 100 kilograms, 220 pounds, and they wanted to lose weight. And we said that the body, if they've been at that level for a long time, it's going to defend against that level. It's like a new set point. So presumably, when we say set point, we're saying that there is a hormonal profile or kind of milieu.
Yeah,
that
it's an established milieu that makes you
maintain weight, or sort of create it. Affects your appetite in a way such that you stay at the same body weight.
Exactly. So,
and now what you're saying is, say our goal is 70 kilograms.
So you need the tool, let's put it this way. You need the tool, right, to affect, number one, appetite. And number two, so what happens when we eat, right? Without thinking about it, right? You eat a certain amount of food, which is the appropriate amount for you, right? And then you feel full, right? What does this mean in practice, right? In practice means that our GI tract slows down and tells you, I'm stuffed, I'm full. And then there is centers in your brain, the appetite centers, that say, well, the appetite goes down, right? So with these medications, they act primarily, but not exclusively. They act in certain organs, right? But primarily in two organs. One is the GI tract, and slows down the stomach, the GI tract. So you feel full earlier because you eat food that does not travel down the GI tract. And number two, and that's why some people have nausea and vomiting, if you don't go slowly. And it goes also to the brain and tells you, okay, you will have satiety faster and sooner. right? So if you add 2 or 3 medications, you have much more pronounced effect, and that's why you lose weight longer. Now, let me add one more sentence, because I see your eyes, you get excited with that. If you have less fat, right, as we keep our body weight down longer, you would expect to have less inflammation because you will need less macrophages and less inflammation, right? If this plays a role in the maintenance of body weight, you would expect that you may not need as much medication 2, 3, 5 years down the road when you reach a new steady state. Am I making it too complicated?
Right, yes.
No.
Can you kind of create a hormonal environment such that the body is not fighting back as hard as it otherwise would?
And more than that, you were in a vicious cycle. Can you now create a virtuous cycle with less inflammation, less macrophages that will make your brain work better, right?
And is the idea, I think you just alluded to this, but to kind of get the body back to a point where it can then maintain that body weight on its own accord, or you would be on some of these drugs for the rest of your life?
Well, and again, now this is the future. We are looking into a crystal ball. We have not proven it, but this is how we think, right? That as you create this vicious cycle, ideally you would need less and less of the medications over time to maintain a lower body weight.
The only problem that I see with that,
and we have not proven this. This is a theory, right?
I can see that working amazingly well if at the same time the food environment shifts, so only whole or minimally processed foods are available to people. But what happens once you get that person to the point where they've lost the weight, sustained it, if you haven't changed their dietary pattern, right, and the environment, and they go back to eating hyperpalatable, energy-dense foods, do they just end up back in the same position 10 or 15 years later?
They may, right? So if you don't improve the environment, let's put it this way, and then I'll come to the specifics, right? They will, anyone will be more prone to fall. Right? If you talk to people, though, who are on these medications, right, and we have done these studies, and we have also taken pictures of their brains with MRIs, they'll tell you that the same food that they were eating earlier is much less appealing now. So their brain sees the same food in a different way. So they have more, healthier, right, approach to food. So this changes the way we approach food. Now, there is 3 main areas in the brain, and I hope I'm not going too deep, but this is... So one is the hypothalamus. This is homeostasis. And this has a lot to do. This is functions of our body that we don't feel, don't control. Like our heart works day and night, we don't control it, right? And this is homeostasis, right? Our temperature is the same. We go out in a cold environment and we upregulate heat production, and this is hypothalamus, sleep, right? The hypothalamus has a major role in food intake. We get used to things, right? And things work like that. For humans, there is another set of nuclei in the brain, higher than the hypothalamus, is the reward centers. And a lot of people eat because they feel more rewarded. They need the reward. We need the reward, right? So think about it, right? We celebrate. We eat, right? We feel depressed. We also eat, right? And there is another center in the prefrontal cortex. This is executive function. So you will see where I'm going, right? Executive function is the control. So our brain has a lot of control. So you mentioned earlier about the environment of food, right? I will give another example. We go to a biomedical conference or a wedding, right? And there is a reception. There is plenty of food out there. Some of us, when they get to the food will be more vigilant. Executive function, right? Don't eat. Others, without even feeling, they start, excuse my expression, right? Grazing. Right? And this is how we operate. Executive function, control, right? Reward, and homeostasis. And what these medications do, and we have seen this with MRIs, is that they make you feel rewarded faster.
For less calories.
Less calories. And you have better executive function. These areas of the brain light up, which is amazing.
Right. I've seen some interesting, at least anecdotes, and you've probably read about this, where people have been prescribed with a GLP-1 agonist for weight loss, but they also perhaps have had an issue with alcohol or gambling.
Oh, yes.
And have noticed that it's actually helped reduce other behaviors that they would classify as destructive.
Beneficial and unintended, right? Consequences of using these medications, right? Yeah, it's true. We have not studied it very well, but it makes sense, right? I mean, I told you about the reward centers, the control, right? Yes. So this is, it's not scientifically proven at this point, but there is enough reports for people to start doing trials.
Right, and there's some mechanistic kind of plausibility, I guess, there.
It makes sense, right? I told you, several years ago, I had a neuroscientist, very good neuroscientist in my group, and we decided to do, she did it, I helped design, right? The studies putting women, obese women and men, right, in the magnet, MRI, do neurocognitive and neuroimaging tests. Neurocognitive testing is like questionnaires, right? You know, prone to gambling, you know, stop, non-stop, right? You drive, right? You see the yellow sign. Do you speed or do you stop? It's simple things, but right? Smoking, as you said, alcohol. Before and after giving these medications. And actually see the areas of the brain, the reward centers lighting up, or the executive centers lighting up, and correlating with the neurocognitive testing. So there is the physiology background. Whether we prove it or not remains to be seen, but chances are, knowing the physiology, that we will see that these medications have an effect. That's what I would predict, right? We'll see. You may invite me like in a couple of years and we can talk more.
Of course, you're always welcome back. You guys know this already. At the center of good health lies a healthy microbiome. When you feed your microbes, they reward you with drug-like compounds that improve blood sugar control, lower inflammation, act as precursors to important neurotransmitters in the brain, and plenty more. Step one in achieving this is a prebiotic-rich, plant-based dietary pattern. If you want to go a step further, you can add a prebiotic supplement to your diet, providing your microbes with extra fuel to grow stronger. I personally start my day with 38 Terra's Daily Microbiome Nutrition, or DMN, which I had the privilege of formulating alongside gastroenterologist Dr. Will Bolsowitz. This is hands down a best-in-market, complete prebiotic with clinically proven ingredients such as actazine and solnol that have been shown to improve gut barrier function and normalize bowel movements. It's like doing the reps in the gym, but for your gut. Get 10% off your DMN at 38terra.com using the code THEPROOF. That's 38TERA.com and use the coupon code THEPROOF for 10% off. So, I mean, here we've kind of skipped forward a little bit into treatment of obesity. If we take a step back, we were talking about why some people have less capacity to store fat subcutaneously.
Yeah, so this is genetic, epigenetic, right? The storage space. And number two, some people have slower or faster metabolism, right? Where
does the fat that ends up building up in the liver, where is that fat coming from? Is it just fat in the diet? Is it glucose being converted to fat?
Yeah. So for the liver specifically, like it is coming from 2 or 3 sources. One is from the diet. Right? So the more, can I use the expression junk food one eats, right? You know,
you can describe it however you want, Professor.
Yeah. the, the more the liver is flooded into triglycerides and lipids, and they will be absorbed by the liver. So this is one area. The second area is as we become more insulin resistant, this is where the vicious cycle starts, right? So we talked about fat being deposited ectopically in the muscle, causing insulin resistance. This insulin resistance mobilizes triglycerides and fat from our own normal subcutaneous fat and creates more triglycerides in the bloodstream and is flooding the liver, right?
So the skeletal muscle insulin resistance precedes the liver build,
so
the fat building up in the liver.
Right. And then there is a third step in this vicious cycle, right? The liver becomes insulin resistant, and it creates what we call de novo lipogenesis. Inside the liver, there is more fat created.
So this is, I guess, a downstream consequence, what I'm hearing, of genetics and energy toxicity. So too much energy.
Right. So our environment, right, builds upon our genetics. So genetics is given. So some of us are more fortunate, others are less fortunate. And the environment, right, what we eat, how we eat, like whether we exercise or not, right, where we live, is building upon it. And then it's a slow process, takes years. This is not going to happen overnight, right? It takes years.
Yeah, what's the average age that someone might develop non-alcoholic fatty liver disease?
It's the middle age. Is the average age, is the middle age. But there is certain populations, if you think about it, like the Latino population, right? South America, they develop it earlier and they have more fat in their liver. So it depends. It takes about 5 to 7 years to go from fatty liver to inflammation, steatohepatitis, and another 7 years to go from inflammation to fibrosis, right? So it's a slow process.
Is fatty liver disease, I mean, at least it seems to me, in the literature, it's being written about more and more and more, was, in terms of the world of metabolic conditions, was it less appreciated at the beginning of your career to now?
Oh, of course. So we'll come back to physiology in a minute. When we started, Simon, we did not know what this is. We would call it cryptogenic. Cryptogenic from Greece is crypto, is like, right, is hidden. And genic, genesis, right? The pathogenesis, the etiology was hidden to us. We did not know what we were talking about. It's a nice way to say we don't know anything about it. Cryptogenic. And then we started realizing what it is not. So we called it non-alcoholic fatty liver disease. It was a negative. So people with alcohol who abuse alcohol, they may have a liver problem. We said, okay, this is something different. We did not know, right? And only recently, last year, we established the new term, which is metabolic dysfunction fatty liver disease or steatotic liver disease, right? So muscled.
It's one hell of an acronym.
Yeah. And this is work in progress, right? This is work in progress, but certain people felt that fatty liver conveys a certain stigma with it. So let's use again, like an ancient Greek word, steatotic, which is exactly the same, but does not have the stigma. So it's metabolic associated steatotic liver disease. Will change again. But this reflects, right, our changing appreciation of what is happening. We would like to have, ideally, and we'll see whether this, we get there, but a refined diagnosis, right? So we talked about what goes in, right? Let me explain also what happens inside the liver, right? And I'll come back to this, right? And I will surprise you with a couple of things. But so, okay, fat is accumulating in the liver, right? But we said one way to remove it is through macrophages and inflammation. And the other way is our mitochondria, which is the energy factory of our body, right? So we'll try to burn more.
In the liver. So
In the liver.
mitochondria in the liver.
In the liver.
Okay.
So again, a balance, right? But how do we get there, right? So the elephant in the room, I use this expression, right, is obesity. Our society is obese. Okay, we know that, right? But not everyone who has fatty liver disease is obese. There is certain individuals, as you said earlier, right, more rare, that either they don't have subcutaneous adipose tissue, they're born without adipose tissue. We call them lipodystrophic individual.
That's the extreme scenario.
Extreme scenario. Generalized lipoatrophy. It's atrophic adipose tissue. Or their adipose tissue is destroyed during their life. An autoimmune process, like lupus or arthritis, or medications people take for HIV. They develop a certain phenotype with lipodystrophy. So they have the same complications that someone has with obesity, although they are extremely lean. And why is this happening? Because it's ectopic fat. The fat they eat will have to go somewhere. If you have no storage space, even if you're lean, will go to your liver, your muscle, and create the same problems, right? There is a third group, right, out there. As we grow older, especially men, we develop sarcopenia. What does this mean, right, for the people out there? Our muscle mass goes down if we don't exercise, right? And this is a third factor that feeds into the problem. So we say that, okay, it's ectopic fat, but listen, in the future, if we want to treat it, we cannot treat an obese person the same way with someone who has sarcopenia. In someone who has sarcopenia, we need to give a medication or exercise to build muscle mass. Or someone who has totally destroyed subcutaneous fat, lipodystrophy, we need to give a different treatment. So going from muscled, we need to have sub-classifications.
I imagine there's some overlap there too with a fair percentage of people with obesity as they're getting older also experiencing sarcopenia.
Overlap. They have sarcopenia and obesity. So there is a fourth group.
Over fat, under muscled.
Yes. So you will see, and I have not seen it, but if I had to bet, I don't bet, but I will bet, right? That in the future you will see a GLP-1 like medication bundled with a muscle building medication for people who have this overlap. And we need to know as doctors, right, which subgroup our patients fall into so that we give the appropriate treatment to the appropriate people. Does it make sense?
Hopefully bundled with some resistance training.
Of course. So everything, all the treatments, even the GLP-1s, the medications you mentioned earlier, right, they should be acting on a platform. And the platform is the appropriate diet and exercise. And pharmaceutical companies have been burned. As endocrinologists or metabolism doctors, we know that. You know that, right? But some people who built trials for the new medications for fatty liver disease were people who were not thinking the same way. They were approaching it from a success story of treating liver disease for hepatitis C or B, right? Hepatology or gastroenterology. They did not use this platform in the clinical trials. So guess what? They randomized people to one medication or the other, placebo, right? And they thought the medication would have spectacular results. Well, people who were taking the placebo, they did not see much improvement. So what were they doing? Improving their diet and exercise. And at the end of the 1 year of the 2-year trial, hundreds of millions of dollars, the two groups were so close that you could not detect a statistically significant difference. So everybody needs to be on a diet and exercise, and then you build with the medications. If you have someone who has hyperlipidemia or someone who has diabetes, right, we start with diet and exercise, and then you build with the medications.
We were talking about the Mantzoros classification when we were kind of clearing up some of the nomenclature here.
Yeah, so if this may stick as a name or may not, but in essence, this is going to describe the subgroups. That's how we call it, right? So it's a soup of acronyms, right? So we called it muscled earlier, right? But we said, well, we need to go deeper. So we need to have muscled lipodystrophy. We need to have SLD, sarcopenia. We need to have MS SLD. So different subclassifications, and we are used to it in endocrinology. For example, a lot of people out there are familiar with diabetes or thyroid disease, right? So we talk about hyperthyroidism, but it's different to have Graves or autoimmune thyroiditis or other causes because you give different therapies. For diabetes, it's different to have type 1, type 2, you have 1.5, right? Give different therapies. So we need to have more refined classifications in the future. We're not there yet because we're still developing capacity now, but we'll get there. That's how I see it in the future.
Does the type of nutrients that we eat affect liver fat, or is it simply a game of calories and energy?
I think it is calories, energy, and quality. So it's not macronutrients. So you said earlier about I think we touched upon it, right? High carb, high fat diets, there's fad diets out there. Right? These diets may have a faster, more pronounced effect in 6 months, but after a year or two, you go back. So a more balanced diet is the one that has a more pronounced effect over time. And a more balanced diet, if you come from the Mediterranean area, is the Mediterranean type of diet. If you are in America, it's a modified Mediterranean diet. We call it DASH, so a more balanced diet. This is what, in terms of macronutrients. What we have also found is that the quality of the diet is also important. So people are familiar with respect to the quality of the diet for diabetes or cardiovascular disease. And we see exactly the same for fatty liver disease.
And that's independent of calories?
Independent of calories. So level 1 is calories. Level 2 is thinking about patterns of diet, right? Not individual foods, but patterns of diet, right? So more, less animal fat, more fruits and vegetables, right? Less sugar, less saturated fat, right? And all this with olive oil, with antioxidants and polyphenols, right? So this is more fish, less red meat, right? So this is patterns of diet, and we characterize them as Mediterranean type or DASH diet. But even each and every vegetable oil is not the same. Each and every, say, fruit intake is not the same. So it's not the same to eat an orange, to drink orange juice, or to drink canned orange juice that has been processed right. And we know this from epidemiology studies. We have done several studies. The quality of the diet is also important.
Right. So within that dietary pattern and selection of foods, trying to focus as much as possible to unprocessed or minimally processed foods. Are there any specific nutrients outside of macronutrients, whether it's micronutrients or supplements that are supported by any level of evidence for supporting liver health?
Yeah. So we'll see more and more in the future, but the best supported vitamin at this point for fatty liver disease is vitamin E, which is an antioxidant. And since we were talking about inflammation, it makes sense. It has been studied in observational studies, but also in interventional studies, randomized placebo-controlled trials, animals and humans up to 2 years. If you give 800 units of vitamin E, it works very well.
Daily.
It works very well for fatty liver disease if you do not have diabetes. Now, why is that? The explanation I give, Simon, is that if you start having diabetes or cardiovascular disease, the inflammation level is so high that the vitamin is not enough to control it. But if you are in early phases, right, before you develop, you're insulin resistant, you have a metabolic problem, but not fully blown diabetes, it's early enough for a vitamin like vitamin E, an antioxidant, to control the problem.
Mm-hmm. What percentage of people with type 2 diabetes would have fatty liver?
Ooh, this is a very good question. And you will be surprised. 70% in America, 70. And we did not know anything about it until recently. So people would come to our clinics and we would not even test.
And so fatty liver,
they go together.
Would that often precede type 2 diabetes?
They go together. Depends on your genetics. Sometimes it does precede type 2 diabetes, most of the time. Other times, if you are more prone to develop diabetes, it's the same process as I told you earlier. So they go together, hand in hand. And guess what? Hypertension and cardiovascular disease. So they're all kids on the same block. Let's put it this way, right? They go together. So if you are diagnosed today with type 2 diabetes, you need to be tested for fatty liver disease. Until like last year or 2 years ago, we did not know that. And if I was diagnosing someone with type 2 diabetes and fatty liver disease, I would bet this person has a certain degree of cardiovascular disease.
So you'd be looking at ApoB or LDL cholesterol, these sorts of things. And if we spoke about assessing your liver health before, but if someone had type 2 diabetes and you're wanting to know if they have fatty liver, what's the gold standard assessment that you're going straight to for that person?
Yeah, this changes by the month. Now we have, the gold standard would be a biopsy. I see your expression, right? I have the same expression, right? And I can support this with numbers. If we had to do biopsies in 30% of people today in the USA alone that have fat in their liver, we had 14,000 excess deaths and hundreds of thousands of hospitalizations because it's invasive. We don't want to do it to everyone. So we need to screen. Expensive, pretty accurate, is MRIs. 2,500, 3,000 a piece, expensive. We will break the system if we have this, right? So now we have non-invasive tests. We try to put together, right? We call FIB4, right? Platelets, easy to measure things. Liver enzymes, age, as we grow older, right? Still, we are not there in terms of sensitivity and specificity. So a major effort in my lab these days, and I'm grateful to the state. I just found out that they renewed our grants. They gave us another $2 million for the next 2 or 3 years, is to do a liquid biopsy. So we've been working on it for the past 2 years. And simply speaking, right, is we measure everything the clinic can give us, electronic health record, age, diabetes, all the clinical data. We measure hormones, but also metabolites, proteins, lipids, proteomics, lipidomics, thousands of molecules.
So you're looking for a signature.
Yeah, agnostic, right? So you have 2 ways to approach things, right? One is hypothesis-driven, physiology-based. We talked about it. The older we are, age, right? Glucose, right? The other one is agnostic, right? In the past, we could not analyze dozens of thousands of data, right? But now we have artificial intelligence. So we ask the computer, go to all these thousands and thousands of data and pick 3 to 4 molecules that have the highest sensitivity and specificity. And we want it to be more than 95% sensitive or specific, right?
And so that's being correlated to a biopsy. Is that how you're doing that?
So we start with a biopsy and we say, if I have a biopsy in 1,000 people, right? And I collect all their data, can the computer give me 2 or 3 molecules that I can put in a new test that would correlate with a biopsy with 95% or higher sensitivity and specificity.
And then the reason why that would be amazing is hopefully those tests are really accessible, cheap, non-invasive.
Exactly. So you can have it in your laboratory, go in the morning fasting, right? Have a blood draw like $50, $40, $60, something that is reasonable. Not, $2,500 or $10,000 that we pay for a biopsy with high risk. So we need to make it more accessible, less expensive, easy to do. Yes.
I have a question that comes back to the physiology again.
You see how many things come up during a discussion, right? I couldn't imagine it when we started.
No,
okay, good.
I know you asked me how long this is going to go, and I said, just trust me. Are you still trusting me?
How long have we been talking until now?
It's 90 minutes, I guess.
Wow, 90 minutes?
Hopefully there's still people listening.
Wow.
I know I laughed when I've obviously... I know your resume, and I looked up on YouTube, and I laughed that I found a 17-minute talk, and then I found one talk from 8 years ago, and I thought, gosh, how has Dr. Mantzoros not been on other podcasts? It was amazing to me, but this is my favorite thing to do. So
maybe we need another one, right, to go deeper into things. But we covered a lot, right?
Yeah. Let me be greedy and ask one more question.
Sure.
Well, two more. We kind of diverged off the supplement micronutrient topic we were covering. Is it just vitamin E, or are there any other micronutrients or supplements that have evidence to support their use for someone with fatty liver or to prevent fatty liver?
So the best evidence we have is with vitamin E. There is some evidence, but not fully proven, so I cannot recommend it, for vitamin D or other micronutrients. There is also some evidence from observational studies that coffee, so moving from micronutrients, right, that coffee helps. But we have observational data, right? We don't have clinical trials.
Any
so
proposed
all we can say, I'm sorry?
Is there a proposed mechanism like the polyphenols or?
Yes. So this is what we have proposed in the past and others, right? There is also certain chemicals in coffee, but this has not been proven in clinical trials. So how do I translate this into talking to a person out there? So at this point, we know that people who drink more coffee, they are more protected. But we cannot tell, right? Start drinking more coffee. Right? Because it could be true and unrelated. You understand what I mean, right? So we need clinical trials to make a recommendation.
But you drink coffee?
Know. I do. And I drink a lot. and I think it's a reasonable thing to do in anticipation of the results of the clinical trials. But there is groups of people or nations, and I was surprised to find out this. We did some of our epidemiology studies in Sweden, and Sweden is a paradise for epidemiologists because everything is recorded. And people there drink a lot of coffee.
How much coffee do you have a day?
I have 3 cups a day. Most of the time you see in observational studies, if you go to Sweden, they drink 10, 12 cups of coffee. You see the benefit instead of water maybe. I'm exaggerating. You see the benefit increasing after 3 or 4 cups.
After 3 or 4, or plateaus at 3 or 4?
No. You see it going up.
I'm not sure I would sleep that well if I had more than that, but particularly later in the day.
You know what happens, Simon, I think, right, for most of us is down-regulation of the receptors in the brain. So you will hear a lot of people drink coffee and they can sleep fine.
So you think they just desensitized from exposure?
They desensitize their receptors, or they are more prone, right, to live with more coffee. As I said earlier, we know that these are observational studies, right? So their lifestyle may be different. So that's why we cannot generalize. We had been burned there in the past, right? You know the story about estrogens. I don't want to waste, our viewers' time. But
tell us.
Like 10, 20 years ago, there were very successful, large observational studies showing that women who take estrogens estrogen replacement therapy after menopause, right? They would be protected from cardiovascular disease or from, you name it, right? And they would live longer and healthier lives, right? But these were observational studies. People started looking into mechanisms, and this would not make sense, and started doing clinical trials, and we found that, well, no, people who take estrogens have more breast cancer or they have more diseases, right? So what was the problem?
Is that universally true?
Yeah, we call it uncontrolled confounding. So if you do epidemiology studies, right? You mentioned about Dr. Willett, right? He's the premier epidemiologist with the most citations. I was looking at the rankings the other day, and he is number one with citations, right? But in epidemiology, you cannot control for everything you observe. You make an observation, but you may have what we call uncontrolled confounding. If you don't put people on a clinical trial to control for everything, you cannot be 100% sure.
They'll try and kind of adjust, but it's not going to be perfect.
Yeah, you can adjust for two things, right? Number one, what you can think of could be a confounder. And then what you can think of and what is available to you. So you can think about this certain things, right?
Just back to the estrogen point, though, I thought and you're the endocrinologist here, but I thought in the menopause, the guidelines, I thought estrogen based on clinical trials was indicated as long as someone didn't have a history of cancer.
Yeah, so if you don't have a history, is indicated for a short period of time.
In a window.
But not forever after menopause, right? For 20 years or 30 years.
Yeah. Right? It's within 10 years of menopause?
Okay. Very short period of time after menopause, and if you don't have any other issues. The very first studies, if you go back 20 years ago, from Nurses' Health Study or other large epidemiology studies, they were thinking that estrogens is the best thing after sliced bread, right? You can put it in the water, and the same is true for androgens in men, but that's another podcast. Testosterone and aging men.
Is that an area of interest for you?
It's a secondary interest, as we don't do research in this area, but as an endocrinologist, we see people, right? And yeah,
it's a topic I wanted to cover, so maybe you can recommend someone that I could sit down with.
Yeah, this is a hot topic, and until recently, a controversial topic without a lot of data. But now there is more and more data coming in from trials. So do it in like 6 months or a year, because you will have much more data to talk from trials, not from observational studies.
Okay. Well, with your help, I'll try and organize that. Last two questions I want to cover before we land the plane here. Coming back to the fat in the liver. These are more about the pathology and what's sort of happening from a mechanistic point of view. Why does increasing fat levels in the liver cause insulin resistance, or what's the relationship between the fat in the liver and insulin resistance?
Well, it's a vicious cycle, right? So the more insulin resistance you have, the more fat you produce, right? And the more fat you produce, there is certain bad fats, right? We can call it this, right? That go inside the cell, right? And create insulin resistance. So for the same amount of insulin, when insulin binds to its receptor, there is certain molecules that create insulin resistance intracellularly. So it's a vicious cycle.
And those are fat?
Some of these are fatty acids. So there is some fatty acids that are protective, and there is others that are worsening the problem.
And are they fatty acids that come in through our diet, or are they fatty acids our body makes?
Both.
Both.
Right? They come from the diet, but also our body makes certain fatty acids that when they exceed a certain level, they get deposited in the wrong tissues and they create insulin resistance. So there is a lot about beneficial and bad fats written in the literature, like ceramides or sphingomyelins. So in the ratio of the two, yeah.
Yeah, is that why there is this kind of general recommendation for reducing saturated fat and having more polyunsaturated fats. Yeah, that comes back to that.
So olive oil, for example, is less saturated fat, in addition to the polyphenols and antioxidants we talked about, right? It's the two pathways.
Right. So if you were comparing, say, olive oil to butter,
exactly,
you would expect butter to increase liver fat
more
in a
to create more insulin resistance sooner. Let's put it this way.
Interesting. And that is more of a problem if you're in a calorie surplus than at sort of weight maintenance, or both?
Because if you think about it, right, butter was much more frequently used in Northern European nations, right? And people did not have the heat, did not have, right? They were living in cold environments and they were doing a lot of labor. They needed it. That's why if you went to a restaurant, right, or a tavern, right, in northern Germany, like 100 years ago, they needed it on their table. But today we don't need it. We need to replace it with olive oil. People who were living in the Mediterranean area, they were using olive oil. I mean, this is, in a way, selection, right? Over centuries. People did not know science. They knew what was working, and they were picking it. Does it make sense what I'm telling you? It's natural selection, right? Am I confusing you? Or?
No, it makes sense. I'm following.
Right? Yeah.
But I guess the main take-home point there is that the type of fat you eat matters. It probably matters more if you're eating in a calorie surplus than if you're eating in a deficit. You can get away with a little bit more.
You will burn it.
You'll burn it.
If you need the energy, you will burn it, right? You will burn the butter.
Yeah.
That's the idea.
Yeah, got you. But in today's environment where there's an abundance of calories and most people...
You are not going to burn it. You're going to store it and it's going to have consequences, right?
To round this out here, how would you describe the current state of metabolic health in America for American adults?
I would say that we are in a crisis. It's unfortunate, but our population still, until recently, was getting more and more obese. 1/3 of the population is obese, 1/3 is overweight. If we look at certain subgroups, more disadvantaged subgroups, 80% of the people, 85% are overweight or obese. So it's a crisis. But we understand it. This crisis mobilized science, mobilized the society to have a better understanding. And with a better understanding, in the beginning, we create solutions that are imperfect, expensive, more side effects, less efficacy, but we'll refine it and we'll solve the problem, right, in the few years.
Thanks, Christos. This has been fun. I hope you've enjoyed it.
Yes, I did enjoy it. And I hope your viewers enjoy it.
Yes, and I hope I can
learn and change our lifestyle, all of us, right?
Yeah.
And hopefully in the future we'll
do it again.
Talk again.
We'll do a part 2. Thank you so much for your contribution to science, and thanks for joining us today. Appreciate it.
It was a pleasure. Thank you.
There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.